disease, eating gluten triggers an immune response in your small intestine. Over time, this reaction damages your small intestine's lining and prevents it from absorbing some nutrients. The intestinal damage often causes diarrhea, fatigue, weight loss, bloating, and anemia, and it can lead to serious complications. There are types of celiac disease: classical celiac disease, non-classical celiac disease, silent celiac disease, potential celiac disease, and lastly, refractory celiac disease. For the epidemiology, it affects males more than females. For the age onset, the disease can occur at any age, but we have peak incidence is bimodal, so we have two peak incidences. The first one is at 8 to 12 months or 2 to 3 months following the first exposure to gluten through diet containing wheat. The second peak incidence is 3 to 4 decades of life. The prevalence in the US is 1 to 150, and it's more common in individuals in Northern European descent. For the etiology, genetic predisposition with association to HLA antigens. The more common one is HLA-DQ2, 90 to 95%, alternatively HLA-DQ8, 5 to 10%. So consuming gliadin from grains such as wheat, rye, and barley leads to an autoimmune reaction within the small intestine. For the pathogenesis, first we have symptoms that manifest when a genetically predisposed individual develops an immunological response to gliadin, which is an alcohol-soluble fraction of gluten. Consumption of food containing gluten leads to tissue transglutaminase release. Then the gliadin is modified from gluten proteins. Then the pathogenic T cells react and are activated by modified gliadin, and this will lead to mediated chronic intestinal inflammation, then epithelial damage resulting in villus atrophy, crypt hyperplasia, and loss of a brush border. Lastly, we'll have impaired resorption of nutrients in the small intestine, especially in the distal duodenum and the proximal jejunum, which will lead to malabsorption symptoms. We have different risk factors associated with celiac disease, such as a family member with celiac disease or dermatitis herpetiform, type 1 diabetes, Down syndrome or Turner syndrome, autoimmune thyroid disease, microscopic colitis, lymphocytic or collagenous colitis, and lastly, Addison's disease. For the clinical features, we have gastrointestinal features and extraintestinal manifestation and association. For the gastrointestinal symptoms, patient might have chronic or reoccurring diarrhea, steatouria, fluctuance, abdominal bloating and pain, nausea and vomiting, lack of appetite, and rarely patient might have constipation. For the extraintestinal symptoms, first of all, we have malabsorption symptoms such as fatigue, weight loss, vitamin deficiency, iron deficiency anemia, osteoporosis, hypocalcemia, and in children specifically, they might have failure to thrive, growth failure, and delayed puberty. For the dermatological association, we might have dermatitis herpetiform. Neuropsychiatric symptoms can be peripheral neuropathy, depression, ataxia, headache, or irritability. We also have endocrine symptoms such as autoimmune thyroid disease, type 1 diabetes mellitus, and we have associated chromosomal syndromes that are Turner and Down syndrome. And lastly, we can have other associated conditions such as inflammatory bowel diseases, rheumatoid arthritis, sarcoidosis, and selective IgA deficiency. For the differential diagnosis of celiac disease, we have two main differential diagnoses. The first one is tropical sprue, which is an infectious disease caused by which is a disease characterized by chronic diarrhea with subsequent malabsorption in association with a stay in the tropics or subtropics. The clinical features of this disease is chronic diarrhea and steatouria, abdominal cramps, progressive weight loss, and fatigue, and we can also see features of malabsorption. For the treatment of this disease, we can give tetracycline in combination with folic acid for 3 to 6 months. Celiac disease and tropical sprue have similar features, which are steatorrhea, abdominal pain, and weight loss. But for the differentiation, only tropical sprue responds to antibiotic. The second main differential diagnosis is Whipple's disease, which is an infectious disease caused by Trophirema whipplei, an intracellular gram-positive bacteria. The clinical features of this disease is also similar, such as abdominal pain, malabsorption syndromes, including diarrhea or steatorrhea, but it commonly occurs later in the disease progression. For the extraintestinal manifestation, in 60% of cases, we can have enteropathic arthritis. In 40% of cases, we can have arthritis, especially sacroiliitis, fever, hyperpigmentation affecting sun-exposed areas, polypsoriasis, and lymphadenopathy. And we have, most importantly, the cardiac symptoms, which is valve insufficiency, and the neurological symptoms such as myoclonia, ataxia, and impairment of motor-ocular functions. The most important feature of Whipple disease are cardiac symptoms, neurological symptoms, and diarrhea, and foamy positive macrophages on biopsy. Whipple disease is lethal if left untreated, unlike celiac disease. For the investigations, first we begin with a patient with suspected celiac disease. He might have signs and symptoms of celiac disease, first degree relative with celiac disease, iron deficiency anemia unresponsive to treatment, elevated liver enzyme without discernible cause, signs of osteoporosis in young individuals, individual with autoimmune thyroiditis, hepatitis, type 1 diabetes mellitus, Addison's disease, and microscopic colitis. So this person with low probability, we start with IgA-based serology initially. If it comes back positive, we do biopsy. Positive biopsy, confirmed diagnosis. But negative biopsy, we move to IgG-based test. So negative IgA serology, we move to IgG-based test. If positive, we do biopsy. If negative, we move to second-line HLA testing. Regarding a biopsy, it's usually done using an endoscope. However, if contraindicated for any reason, we go for the video capsule endoscopy. The most important thing is that patient with biopsy-proven dermatitis herpetiform, their diagnosis can be established with a serology test without the need of small bowel biopsy. We also have another test called the gluten challenge test. It is for those who are on a gluten-free diet. We let them ingest gluten about 3 to 10 grams per day for 6 to 8 weeks. That is followed by checking for antibodies against the gluten or a small bowel biopsy. We also have a nutrient deficiency screening, which is a confirmatory test. For the biopsies, at least 4 biopsies are required from the duodenum, especially at the post-bulbar area, the portion of the duodenum closest to the stomach. For the management and the treatment, the main management is by diet. We give the patient a strict lifelong gluten-free diet, abstain from products containing wheat, rye, barley, or spelt. Symptoms usually improve quickly. Recommended foods are rice, corn, potatoes, soybeans, and millets. And patient with secondary lactase deficiency, they should avoid milk products. Other managements are iron and vitamin supplementation if there are deficiencies, such as iron deficiency anemia. We consider osteoporosis screening in adult patients and refer patient to a dietitian and advising to join a support group. Managing celiac disease mainly consists of maintaining lifelong gluten-free diet. Patients with celiac disease might develop complications such as secondary lactase deficiency and moderately increased risk of malignancy, and those malignancies are enteropathy-associated T-cell lymphoma, adenocarcinoma of the small bowel, and esophageal cancer. Patients might also develop refractory celiac disease, which is persistent and worsening of celiac symptoms despite strict adherence to gluten-free diet for 12 months. This condition manifests with one of 3 possible courses. The first one is only partial improvement despite a gluten-free diet. Second is initial improvement by relapse despite maintaining gluten-free diet. And lastly, non-responsive celiac disease, which is no response to gluten-free diet. And patient with refractory celiac disease, this disease may lead to ulcerative duodenitis. In severe cases, total parenteral nutrition and treatment with a steroid or immunosuppressants may be necessary. For the prevention, there is no proven measures to prevent celiac disease, but with infants, introducing small amounts of wheat into the supplementary diet between 4 to 6 months of age does not increase the risk of developing celiac disease. So we can't prevent it, and there is no increased risk. This is a recent study about celiac disease, which is phenome-wide association study in adult celiac disease. We will discuss the role of HLA subtype. So, as a background, celiac disease arises in genetically susceptible individuals, in particular in carriers of HLA-DQ2, DQ8 risk alleles, and is associated with various comorbidities. Celiac disease may confer an increased mortality, but the data are conflicting. The aim of the study was to characterize mortality and morbidity in patients with celiac disease, with a special focus on the role of number of HLA risk alleles. The method they used is studying celiac disease-associated morbidity and mortality in 500,000 participants of the UK Biobank, including 2,482 individuals with the diagnosis of celiac disease. They used an unbiased, multivariable phenome-wide association study method to uncover the celiac disease-associated disorders. The tag SMP approach was used to divide the celiac disease subjects into HLA-DQ2, DQ8-based risk categories. The results were that they found 225 ICD-10 codes significantly associated with celiac disease. During the median follow-up of 10.7 years, celiac disease individuals, which were 2,482 patients, had higher overall mortality than controls and both an increased occurrence of and increased mortality from cancer, respiratory and cardiovascular diseases. Celiac disease individuals with two HLA-DQ28 risk alleles had a similar overall mortality as celiac disease participants, with 0.1 HLA-DQ28 alleles, but were more likely to die from lymphoproliferative diseases. So as a conclusion, they concluded that the data suggests that the increased mortality from lymphoproliferative diseases is restricted to those celiac disease patients with two HLA-DQ28 alleles, and that a combination of celiac disease and HLA-DQ28 alleles is needed to increase the susceptibility. Once confirmed, closer monitoring may be warranted in this high-risk subpopulation. So those are the references used, and thank you.
Excellent, Ala. Well done. I see the number only 29 people attending, or more than that? Because usually
46, Doc.
46, huh? Okay,
Yes,
because I don't know, the screen says, okay, good.
Yeah,
so any question for Ala?
No, doctor, she did extremely well.
Okay. Celiac disease is theoretically is a nice subject, easy subject. But when you go to the practice, it is really not that easy. This is, by the way, a very common area for questions for exams, either MCQs or even clinical. But when you go to the real life, it really represents one of the diagnostic challenge because most of the cases are atypical. If you have a typical case who present early on life during infancy, after the introduction of the cereals, with typical history of diarrhea, weight loss, wasting of the muscles, serological abnormalities, positive biopsy. This is classical case, easily managed, but sometimes you see a late presentation. Even nowadays, we are seeing adult and adolescent who's presenting with celiac disease, which is sometimes represent challenges, especially if the serology is not, convincing to the clinician. Serology improved significantly lately, In the past, we used to have the IgG only. Nowadays, we have the IgA. But in this case, as Alas said, you have to measure the IgA level. IgA level total has to be. I mean, the patient should not have IgA deficiency. Otherwise, the serology of IgA serology will not be really accurate, will give you false negative studies. So this is why we do an IgG if the patient has IgA deficiency. After diagnosis is challenging. In the past, they are more aggressive in the approach of the diagnosis, because they do serology. If it's positive, they do biopsy. Then they put the patient on gluten-free diet, re-biopsy again, challenge, and biopsy. So 3 biopsies are done. But nowadays, one-time biopsy with the serology will be adequate. I'm sure in the future we'll have genetic studies that also support the diagnosis. And as we can see in our practice, we are moving to a lot of genetic studies, avoiding all these invasive approach. For example, there is a lot of genetic diseases causing chronic diarrhea. In the past, we used to do intestinal biopsy, microscopy, and special studies for that. And nowadays, they don't do even endoscopy. They just do genetic testing for specific mutation. For celiac disease, it may come in the future, and it may change this kind of approach. After the diagnosis, the challenge is really the diet. Diet is compliance is a difficult issue, especially with adolescent and adult, and it is expensive on you to get gluten-free diet, not that cheap. And now it's becoming more. In the past, it is difficult to find food which is gluten-free. Nowadays, there is corners on the supermarkets and the on special shops for gluten-free food and products. So it's becoming more available, but the problem is with the compliance. Okay, so that will conclude the session. And do you have any question, or we can move to the second subject? Who is the moderator here?
العنود وهاني, but I think they don't they are not around currently, but we can go, doctor.
Okay. The second subject is the pediatric screening. Who's I think Noor is the one who's supposed to present. Noor
Yes,
Adnan.
doctor, it's me. Yeah.
Okay. Are you